Good afternoon, everybody. This is Erin with the Department of Medicaid. It's not quite 1 o'clock and we're still clearing 2 o'clock, excuse me, clearing out the waiting room. So we'll give it just a moment before we get started.
Hi, Aaron, it's Keith. How's the waiting room looking now?
It is starting to clear out. About every time I get it cleared, we have some more people join.
Okay, we'll give it another minute or so.
The commissioner did ask that I let you know she's going to try very hard to get here. She has some overlapping meetings. It may be towards the end of the meeting, but she is going to try to join us today.
Okay, thank you.
I was having a little trouble with my computer audio, so I called in also.
It's interesting you say that, Steve, because my computer speaker also went out ever since the Friday outage of all the medical systems, and it still has not come back online. So I'm having to uh, go back to conventional means for microphone.
Yeah, that was a bad one. Hopefully they've got all that, get it worked out in the next few days.
I know there's a lot of doctors out there that are not happy because they've spent all weekend basically taking the written notes from Friday and putting it into the patient medical record. So Lord only knows what is going to be floating around in Epic and Cerner and these other systems over the next few days.
Your waiting room is cleared.
Okay, very good. Well, welcome everybody to our July EMS TAC meeting. Let's go ahead and get the roll call and we'll go from there. Aaron, would you mind running that for us, please?
Sorry about that. I was trying to admit more people.
Oh,
I have Joshua. Or Josh, do you go by? Oh. Keith.
Present.
Linda.
Present.
Dana.
Present.
Troy.
Present.
Stephen.
Present.
Very good. Looks like we got quorum.
I think I got 4 out of So I think you need one more. Hold on, sorry. I can't read and talk at the same time. My apology. Or count and talk and
Fine.
read.
I think we have 5 of us on here. We've got Troy,
Okay.
myself, Steve, Linda, and Dana.
Dana. Oh, I missed Dana on my check off. Sorry about that. You do have a quorum.
It's all good. It's all good. Very good. Glad to hear that. Next thing on the agenda, let's go ahead and move to approve the minutes from the April meeting. The minutes were sent out. I know it's been a while since we had our meeting, but the minutes were sent out back in April. Hopefully everybody has had a chance to take a look at the minutes.
Motion to approve.
Very good. Thank you, Troy. We have a motion. Do we have a second?
I'll second.
Thank you, Linda. Got a second by Linda. Any discussion on the minutes? Hearing no discussion, we'll move for the vote. All those in favor of approving the minutes, please signify by saying aye. Aye.
Aye.
Any
Aye.
opposed?
Aye.
Any abstentions?
Can I please have our voting members on camera, please?
There we go. Do we need to do the vote again? Or are we good?
If you don't mind, that would be great. Sorry.
No worries. No worries. All those in favor signify by saying aye.
Aye.
Any opposed? Any abstentions? Vote carries. Thank you, everybody. All right, going into old business. We had started talking about during our last meeting the issue we had regarding Medicaid reimbursement for EMS services. We had a presentation by Mr. Paul Phillips with GMR. It was a very good presentation. He brought forward a lot of information that I think we all have dealt with at some point in our careers and have struggled with regarding the reimbursement factor, especially the T2005, which we'll discuss a little bit more under new business. But at that time, we had agreed that we would have try to have a subcommittee or a subgroup meeting with some of the MCOs to decide or look at what could be done in order to potentially increase the Medicaid factor, especially for non-emergency transports that we're doing. It was noted that under the GEMT program that services were doing better than where they were before the GEMT program, but it's still not great reimbursement, but at least it's still better than what we're getting on the non-emergency side. I received a email from the commissioner, it's probably been about a month ago, that she would like to just have a quick talk about it because she wanted to get some points that she wasn't sure about. And she and I had the opportunity to talk last week for a period of time. And it was a very good discussion with the commissioner. I think there were some points about our reimbursement schedule that she was not aware was actually going on in Kentucky. She seemed to be very concerned, legitimately concerned of the issues we're having. Basically, I briefed to her the issues that we have because of, or partially because of the low reimbursement rate with the EMS services that are and have been struggling over the past few years. And it was obvious that we need to do something here. In fact, last year, and I'll just run through these real quick because this was information that we didn't readily have available in April, but I have been able to get it since. And that is, last year we had one private EMS service. Actually, let me back up, 3 private EMS services that closed the doors. Those counties had to go back to the drawing board and find other means for being able to get EMS coverage in their community. There are currently 2 counties that are in talks about merging into one department because they simply cannot survive as 2 separate. There are 2 more services in southeastern Kentucky that are considering closing their doors because of financial reasons. We have some services that are refusing to do any Medicaid transports because the reimbursement rate is so low that they simply cannot afford to do the transports or they'll go out of business. There have been other counties that have had to drop their ALS coverage. In fact, one of the votes that we just recently did at K-Beams, which quite honestly brought none of us any good feeling whatsoever, was we had to lower the threshold for what equates to an ALS service in Kentucky, to where we had to start allowing advanced EMTs being the highest level of advanced life support coverage for a county in order to stay licensed in Kentucky. That was a very difficult vote to have to take. However, if we didn't take those actions, we would have multiple counties in Kentucky that would have to surrender their licenses to operate. And that's simply not a alternative that we can stomach as well. One of the other factors that we have that is a contributing factor to the financial issues is the fact of the closest appropriate facility rule that basically states that Medicaid is only going to reimburse a service for transporting to the closest appropriate facility. In theory, that sounds great, but when you're picking up a patient that is a patient of a hospital system, they've got a receiving physician that is in another hospital, a good distance away from the closest appropriate. The payment for that reimbursement stops at the mileage of the closest appropriate instead of going all the way to where the transport is being made, which means at that point, the EMS service is doing the transport for free. And we simply can't afford that any longer. So all these were factors that I had relayed to the commissioner about why we were asking for a review of the Medicaid reimbursement, and why we really wanted to bring up the discussion of the T2005 a little bit more. With that, I know I just said an awful lot. I'll be quiet for a moment, open it up for the TAC members or any of the MCOs that if you all have any questions about the information I just presented, please feel free to let me know. All right, awesome. So from the old business standpoint, that's where we were at. Commissioner Lee did indicate that she is going to try to attend our TAC meetings as she can. Obviously, she's a very busy person having the role that she has. She did commit to try to make this meeting if she could. And just as Aaron said, she is still going to attempt to get on the call. A couple of the things that we had actually talked about during the call as possibilities, and this is where I would really like to get the input from the TAC members, the EMS TAC members, is the thought of knowing that we just ended a reimbursement session or a financial session of the legislature. It's going to be very hard to go back and get any additional funds for the next year and a half because of the biennium budget in Kentucky. Is there any chance, or do you think there is any palpable desire to try to incorporate non-emergency transport reimbursement into the GEMT program, so long as the federal government would agree to such? So from the perspective of EMS services, do you think that is something that the providers would go along with? Do you think that that may create a bigger financial burden because of the amounts that each service has to contribute back to the fund in order for it to pay? What's the thoughts of the group on that?
We would be open to that.
Okay.
Keith,
Yes, ma'am.
in doing these recent reconciliation reports, I discussed with Bradford at Myers and Stouffer the fact that they're asking on that report for the number of non-emergency runs, but yet they are not counting non-emergency runs under the 5,600 number. They're only counting non-emergency runs under the 55 number. There shouldn't be, well, there should be very few under the 55 number, since that's the emergency number. How do they correlate that?
That's a fantastic question. I'm going to be honest with you, as I have been disconnected from the GEMT program. Troy, do you know more about the program where you could comment on that?
Not enough to comment on that question. I'd have to check into that, Linda.
I think it is certainly something that we need to get an answer on, because if this could end up being a avenue for us to be able to get a higher reimbursement now, while we wait for another year and a half for the legislature to have a funding session, something's better than nothing, and I think this might be a good move for us. Any thoughts on that?
Secondly, I've asked for a phone call to be able to reconcile how we are to, I mean, hardly any of our providers matched 100% what their estimate payment was based on to what we actually got paid on. And I have asked for a meeting with him, a phone call, and I have yet to get that. So since I only had like maybe 2 providers that were only off a couple calls, I'm still in limbo waiting.
Hey, Linda, this is Jacob Wilson with Medicaid. If you could give me that information, we can get that meeting set up for you.
Okay, thank you.
Yeah, if you could send me your question and everything, we'll get that meeting set up pretty quick. Okay. My
Okay.
email's I'll put it in the chat.
Okay, thank you.
All right, thank you.
All right, very good. All right. Any other comments about the GEMT or the Medicaid reimbursement to this point?
Hey, Keith, this is Stuart on with WellCare.
Yes, sir.
So you're talking about the supplemental payment program, right? The tax, the provider tax to get the higher reimbursement, right? And I know just a thought for the limit is higher through managed care. You're able to get more money basically if you do it through managed care, and non-emergency is fee for service. So I think the limit for that is the Medicare payment ceiling or whatever. So it would not be as much money. I mean, that's just a thought.
Mhm.
It would not be as much money because you can have a higher payment for if you do it through managed care, and that's like part of the federal regulation. So that's just a thought.
Okay, thank you, Stuart. I'll be honest with you all, when it comes time to the billing portion of this and all the rules and regulations, that's where I'm going to lean heavily on Linda and Dana to advise us, because that's one area that I am a complete idiot about, to be frank. That being
Federal
said,
rules are not easy. Federal rules are not easy to understand.
they're not. And I'll tell you, I've had a discussion with a provider who just recently got licensed in Kentucky that came from Indiana, and they were able to get their Medicare reimbursement rate 4 times what the Medicare allowable rate was, because of what the EMS providers were basically charging to the MCOs, and the MCOs wanted to lower that as much as they could, so they were able to get that lowered. I think 4 times as much as what Medicare allows would probably cause a lot of strokes and heart attacks. But I do think that this shows that it can definitely be increased a lot more than where we're sitting right now. Stuart, from what you just mentioned there about the differences, and your knowledge of the cost sharing program we currently have, can you think of any disadvantages that we would have of trying to go down that road as a Band-Aid fix for now?
No, I mean, so you can still get, like with managed care, for example, we have the same thing with the hospitals, and we pay, it's basically commercial, like it's a percent of the commercial rate for the given service, which is a much higher payment ceiling than Medicare. So if it is non-emergency transport only, it would be fee for service. So it would still be higher. I mean, the payment ceiling becomes Medicare, which is still higher, so it would still be more than now. I mean, it'd still be supplemental money. It just wouldn't be as high as the ceiling for, what's currently in place. But I mean, I mean, I think, of course, the feds have to approve everything.
Mhm.
I know, yeah, and so if it's through managed care, I know there always has to be a quality metric, at least some quality metric tied to it, for that federal, for this arrangement where you pay a tax and get money back. It always has to be, it's considered a state directed payment, like literally the state is saying, this is how much you pay. So there always has to be some kind of quality metric tied to it, and for the feds to approve it, and why are you doing this? What's the reason for it? So that's a consideration. I don't know if that would be the case for fee for service, though. I'm not sure if that would be a requirement or not.
Mhm. Okay.
Just know a few years ago, we was the 49th lowest reimbursed, Kentucky's Medicaid was the 49th lowest reimbursement in the United States. That's just something that really drives that home and makes it sink in how low we are compared to others. So
We one of the last things we did at the April meeting is we came up with a work group. I believe Jacob Carroll was going to be one of the folks to help lead that. I wasn't honestly, I couldn't remember who all was appointed to that. The group that agreed to do that, I believe we had several of the MCOs that were also identified. I'd pull up the minutes and look at it myself, but I can't pull it up on my computer right now. If it's possible for that group to still get together before we have our next TAC meeting and look at alternatives, and also at what we need to look at as far as if we could use the GEMT program, because again, that's one thing that the commissioner did suggest that we look at using until we could get something done regulatorily through the legislature. I think that would be handy to move forward on. So I'll take a look at the minutes here after we get done with the meeting, find out who all it is, and send an email out to the group and see if we can get the ball rolling again. I know Jacob had some health issues and had to have surgery. Yes, Linda, go ahead.
If we increase the non-emergency from the GEMT money, would that lower the reimbursement on any of the other trips?
That's what I'm not sure. I don't know if they would require services to provide more of a stipend back into the program to allow for that increase, or if that would decrease the emergency runs. And obviously we don't want to do something that's going to basically, cut off our nose to spite our face if we're not careful here. So I think that's where we would need to find out from the accounting group that manages the program, what are our different options so that it has the least negative effect, hopefully no negative effect. But I think we need to identify any risks that we currently have to the current program, and also list what our benefits are of doing that based off of the information they're able to provide us. And perhaps that's something that Mr. Wilson and you might be able to talk about when you get the meeting set up with the accountant group, if you don't mind.
Yeah, we can do that.
Fantastic. Thank you, sir. Alrighty, jumping over to new business, and that was the suggestion to delete the 2005 due to mismatch of the services provided. I did a little digging on this because there's always been the question about wheelchair vans, not so much wheelchair vans, but stretcher vans that come into our hospitals and move staff now, or I'm sorry, patients. The question that always comes up is, are they allowed to use stretcher vans in Kentucky to do this? And the question the answer that I've been able to find so far in the Kentucky regulations is no, they shouldn't be doing that. The fact is, though, if we didn't have them doing it right now, we would probably not have very good luck getting our hospitals cleared out. But that being said, looking at 907 KAR 1060, which is the ambulance transportation KAR through the cabinet, and also 603 KAR 7080, which is the human service transportation delivery. Ambulance stretcher transportation under 080 is defined as means an ambulance service used for transporting sick or injured people who are also bedridden. Under the definition of ambulance transportation in 060, it says means ground or air transportation provided at advanced life support or basic life support level by a carrier licensed by the Kentucky Board of Emergency Medical Services. In looking at both of these regulations and going back and looking at all of the internal documents that I could find online through Department of Medicaid Services or Cabinet for Health Services, there is nothing that talks about stretcher vans being used in Kentucky. There are comments to stretcher vans in other states, but there's nothing about them being able to be used in Kentucky. And again, I don't want to cut off my nose to spite my face, because we know that we rely on these folks to help get our patients out of the hospitals. But where I'm going with this is they are getting reimbursed at the 2005 rate by using simply a minivan that they have thrown a stretcher bolted to the floor of the vehicle with absolutely no safety checks to get patients moved, whereas we're operating $300,000 ambulances that have stretcher systems that cost $70,000 that has to withstand a 10G impact. So the equipment we use is far more expensive to operate than the stretcher vans do. And the fact that we're being expected to only get a T2005 reimbursement, which is the $55 and I believe $2 a loaded mile, is absolutely unconscionable. So given the fact that we have the regulations stating what they do and the fact that stretcher vans technically should not even exist in Kentucky, I think drives the point home even further that we have got to do something as immediate as we can to try to get the reimbursement rate where it's at. And if the state, in fact, wants to continue using stretcher vans, then I think the regulations need to be adjusted to allot for that and hold them accountable to some of the same standards that ambulance providers are held to, which drives up our expenses that much more. Obviously, COVID didn't help us any with the cost of equipment, supplies, vehicles, and so forth. But when we're having to spend $300,000 on a vehicle, whereas a company that's a transportation broker can go pay $60,000 for a minivan and get paid the same reimbursement rate that we have to accept from an ambulance service, it's kind of a kick in the face, quite honestly. Troy, I believe that you and I had an email about that. Is there anything else you'd like to add on to that I may have missed?
No, I think you covered it well, Keith. The point that, they're not really legal in the state of Kentucky. And here we are wanting to talk about raising our reimbursement for ambulance transport. And all along we're using a code that's, less. I think it's a good start to get that back to where it needs to be and just get rid of the T2005. But you covered that well, so I don't have much more to add.
Okay, thank you.
I did get a text back about adding the non-emergency to the GMT, and the response was you can't do it because the current CMS rules in place, you can't add the non-emergencies to that program. So
okay,
it would be some changes you'd have to do, I guess is what I'm saying.
all right. As I was speaking there, we did get a chat that came in from Miss Evans from A&B. She would like to be involved with the meeting with Myers and Stauffer as well. Mr. Wilson, if you wouldn't mind making a note of that as well. Also, Mr. Wilson, based off of what the answer Troy just got back on this, where, and Troy, if you don't mind going back and repeating again, what did they say what we would have to do?
There would have to be rules change in the CMS rules to allow non-emergency into that program.
Okay, so that would obviously, if it's CMS, and that would have to be done by the federal government then. Does anybody on the Medicaid side have any suggestions on what we could do to potentially get this in front of Medicare as far as what our situation is in Kentucky to see if we could get this added to it, or are we basically out of luck?
Hey, Keith, this is Jacob Wilson again. I'm not as familiar with this program, but let me get some more information and we can get back with you on that.
Okay, I think what we may be doing is just making your list for the discussion
A
you
little
you all are
longer.
gonna be having with
Yeah.
the accountants a little bit longer. Yeah, okay. All right. Any other comments from the TAC members regarding T2005 or the old business having to do with the Medicaid reimbursement?
Hey, Keith, I think one point, and Linda or Dana, either one, the T2005, is it used by all Macs, or is it just a couple of them using that code?
For Medicaid? Are you talking about the Medicaid?
Yes. Yes, uh-huh.
As far as I'm aware, it's just Kentucky. I don't have any other states using it.
But it is all of the max here in
Yeah,
Kentucky.
I mean, but what the different is it all of them or is it a couple of them?
It's all of them in Kentucky.
Okay, all right, thank you.
Okay. Well, it looks like we certainly got our work cut out for us to work on this. But I feel strong that we could get it done because we were able to get the PCS situation straightened out and working at the advantage of the EMS providers to where they can get reimbursed for that. So I feel like we can probably get this worked out too. It's just going to take some more work to get it done. So, all right. Thank you all very much for your comments. Is there any comments in general, general discussion that any members of the TAC or any of the MCO folks online would like to discuss? All right. Aaron, would you mind scrolling the agenda up just a little bit so I can see where we're at beyond general discussion? Okay, very good. All right. Is there any recommendations that the TAC would like to make at the next MAC meeting? All right, hearing none, I'll take that as no. The next MAC meeting, I believe, is actually this coming Thursday. If anyone is interested in attending that particular session online. And if we have nothing else, then our next meeting is October 28th. But again, I would like to encourage the work group that agreed to work on the Medicaid reimbursement. And I'll check the minutes after we sign off to look and see who all agreed to it and send emails out. I would like for the group to try to get together if possible between now and the next meeting to see what can be worked on at both a local level and potentially a federal level if need be. And then we can take what you all come up with and marry that up with what Mr. Wilson, Linda, and Dana are able to potentially get worked out with the accountants. All right, I believe next would be call for adjournment. So is there any motion for a call for adjournment?
The motion.
All right, I got a motion by Mr. Walker. Do we have a second?
I'll second it.
All right, second by Ms. Bashan. All those in favor, please signify by saying aye. And you got to have your cameras on, folks. Sorry.
Aye.
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 Any opposed?
Aye.
Any abstentions? Very good. We are adjourned until October 20th. Thank you, everybody.
Thank you.
Thank you. Have a
Great
great
rest
day.
of the day.
You too.